Welcome, everybody. We will be starting our presentation in 2 minutes. Welcome to anybody who's just recently joined us. We will be starting in just 1 minute. Okay, hi everyone, and welcome to LLSC's National Leukemia Conference. Though we have hosted this conference for 3 years now, it's the first year of its kind as we come together virtually. Thank you for adapting with us and for joining us today and this week. Throughout the week, we will share educational tools on leukemia as well as stories of hope. This week, you can expect a total of 5 webcasts on critical illness, AML, CLL, CML, and today's topic, ALL. In today's presentation, we will learn more on treatment options and what you can do to minimize the impact and side effects of cancer treatment for ALL. My name is Netta Pajuman. I'm the Regional Director for the Ontario region at the Leukemia Lymphoma Society of Canada, and I will be your moderator today. If you're joining us for the first time today, welcome. And if you are joining us for the second time this week, welcome back. Some of this next few minutes might feel a little repetitive, so bear with us as we welcome new guests. The presentation will last approximately 90 minutes, which includes a question and answer period. Please do feel free to get up, stand, stretch. Your cameras are off, so it won't be a distraction to your speaker. We invite you to type your questions and comments in the question box of your GoToWebinar panel throughout the presentation. An LLSC staff member will be monitoring and can answer any tech or program-related questions. I will ask some of your questions to Dr. Murphy at the end of the presentation during the Q&A period. Due to the number of questions, we may not be able to answer all of your questions, but we'll make sure to get you a reply outside of this session if your question remains unanswered. The conference will be recorded, so don't worry, you can re-listen to it after or share it with family. It'll be available on our website and the link will be sent to you after the event. As we prepare to begin our main presentation, I want to take a few minutes and share our mission here at the LLSC and highlight some resources that might be helpful for you or someone you know. Just going to advance one more slide here. Great. I like to think of LLSC's mission as twofold. We look to the future of care through research, where we aim to find cures for blood cancers, meanwhile addressing challenges today by offering services to improve the quality of life for those affected by blood cancers and their families. Ultimately, we are here to serve you. We offer support and guidance to people affected by blood cancers along the way. And it's important to us to remind you that you are not alone. Please don't hesitate to contact your local community service managers to learn more about how we're here to help. We offer a variety of educational resources and support services to help those affected by a blood cancer. On our website, you can access informational booklets and fact sheets about blood cancers, treatments, and psychosocial aspects of your journey. You can access our resources in a variety of languages, eliminating any barriers related to access. Sorry about that, slight delay. We also have various educational videos to fully understand blood cancer and treatment management. On our website, you will also find the recordings for all of our past webcasts and announcements on upcoming LLSC webcasts. We encourage you to subscribe and listen to our podcast series, The Blood Cancer Experience, to learn more about treatment and research from experts, and to hear stories directly from people affected by blood cancer. Our podcasts are available on Spotify, Apple Podcasts, and anywhere you enjoy listening to your podcast. We recognize that sometimes it's best to hear from someone who has shared experiences to what you're going through. Our peer support program is a support service that matches people affected by blood cancers, caregivers, and their families with trained volunteers who have been touched firsthand by a blood cancer and share similar experiences. It is a supportive program, which is especially relevant today during COVID, where we hope it counters the effects of isolation. While 2020 is not a year filled with many highlights and things to share about, we are proud to share that in June of 2020, we launched a new program called Your Life After Cancer. For the majority of people, the transition between being a patient and being a survivor is not so seamless and straightforward. We know that every cancer experience is truly unique and that every step has a deeply personal impact and meaning. This program offers tools and resources you may need to help you move forward after your blood cancer experience. You can visit yourlifeaftercancer.ca to view our new fact sheets on the important topics such as fatigue, cognitive issues, and how to support a loved one in their transition. You will also find webcast and podcast recordings along with inspiring stories from survivors. Now, what do you say we move on to our main topic? It is my pleasure to introduce our speaker, Dr. Tracy Murphy. Dr. Murphy received her medical degree from University College Cork in Ireland, and then completed general medical training in Ireland. When she moved to Cambridge in the UK to complete her clinical and laboratory hematology training based in Addenbrooke's Hospital. She obtained her FRC pass in 2004. On completion of training, she started her leukemia fellowship in Princess Margaret Cancer Centre in Toronto. She has been on staff as a clinician investigator since 2018. Thank you for joining us, Dr. Murphy, and it's over to you.
Thank you very much. I'm just going to fix the technology here a little bit if I can, so bear with me 1 second. Just moving something out of the way. I like to start every presentation by saying thank you to my patients and to the patients that exist in the world. I can tell you that for me, I try my best to always be there for my patients, and that all of the research ideas and the research that we do in clinical practice is driven by patients. And it's agreed with and worked on and talked about and trying to find the best approach with my colleagues. And as I've traveled around the world, I've learned so much from everyone I've worked with, and we should always try and remember that. I have one caveat to my presentation, and I want to say that, you know, about 10% or more of the things I'm going to tell you will change. This is such a dynamic area at the moment. There's so many things happening from a research perspective, so many clinical trials, that hopefully these things change for the better. But certainly when you look back, you might find something has changed significantly. You might think, well, it's probably because it just didn't happen at that time point and it wasn't available yet. As regards what I'm going to talk about really very simple things. What is the ALL? What is the diagnostic pathway, and how do we assess response? And ideally, how should we assess response? And then I've just broken it down into TALL and BALL, both of which are relatively large topics. So if I don't cover everything, I should apologize in advance. Sorry, my computer just decided to pop up something. So first of all, what is ALL? So the hematopoietic system, or where blood cells are made in the body, is one of the most active systems in your body. Every day it makes billions of cells that you need to survive on a day-to-day basis. And those cells generally are essentially platelets, neutrophils, and other white cell counts and red cells, all of which have a distinct role. Lymphocytes are two of those cells that are involved in fighting infection, typically kind of viral infections, and they're broadly divided into two types, T lymphocytes and B lymphocytes. And TALL and BAL are cancer of those cells in immature forms. When you look at it under the microscope and into the bone marrow, where this is a cancer of the bone marrow, you see these small, relatively small cells. Some of them are often described as having a hand mirror shape, and essentially, typically, a bone marrow in ALL is stuffed full of these cells, typically over 100%, or as high as 100% or 90% in many cases. It's a disease really that's most common in children and most well known in children. A lot of the research is done in that age group. However, some people, as we get older, we see a distinct rise in the number of patients, especially in their 50s and over, and a different change. And I'll be talking about that and how that change happens at a kind of a molecular level. I have given a few of these talks, and I like to give a general overview about diagnosis and assessment of response, because I think it helps us frame the conversation as we're going along. So bear with me if you're a little bit bored for this part, I apologize. So you remember that in acute leukemia, irrespective of the type, at diagnosis, essentially, we do a bone marrow biopsy, or sometimes on the blood, we do tests. And essentially what we're looking for is blasts, which are leukemia cancer cells, that essentially are over 20% in most forms of acute leukemia. Other tests are done in parallel, and we'll talk about those briefly later on, including flow cytometry that tells us the type of leukemia, some PCR cytogenetics, and other genomics, all sophisticated tests. And hematologists are loyal to a point. We never very slowly discard a test. Instead, we add a test on as it's developed, so that can help us refine further the diagnosis and the prognosis in each patient. What usually happens is that when I'm talking to patients in a clinical level, I like to say that leukemia in a bone marrow is like having weeds in your garden. Essentially, there's these blast cells, or these weeds, are preventing your normal cells from growing. So what we need to do is come in with chemotherapy, which is like weed killer, and kill out, or kind of wipe out the bone marrow so that new cells or normal cells can grow. And what we find more and more in ALL is this approach can be traditionally and historically has been non-targeted with chemotherapy. However, it's becoming more and more targeted as we move on. And we're going to talk a lot about that today in our when we talk about treatment options and how they're developing, especially in BALL. We know that the aim of chemotherapy is to get a complete remission, which is less than 5% blasts. And what we often need to do, and when we think about our garden, essentially we want to have a normal, happy garden beautifully with normal flowers and no weeds seen. And what we're aiming for is to sustain that remission, typically giving more chemotherapy and sometimes with a transplant. However, I think the definition of remission is something that's really changing now in hematology for all diseases, and actually also for solid tumours, because we know that for everything we can see above the surface like an iceberg, there's a lot more disease below the surface. And we often call this residual disease. And many of you over the course of your treatment will have heard of minimal residual disease or measurable residual disease and how it can be measured. So if you imagine at diagnosis, you get your treatment and you're in remission with less than 5% blasts. we know that actually you could have absolutely no evidence of leukemia left, with zero, like 1 in 10,000 or 1 in 100,000 cells showing no evidence of leukemia, bearing in mind that it was something like 12 billion at the start. However, for other patients, we see that level of response is not as low, and maybe there's about 1 in 1,000 cells that are leukemia cells. And so when you imagine over the course of the body, that's a large burden. And really what we want to do in clinical medicine and clinical hematology more and more is monitor this level of disease over time, so that when you have your induction chemotherapy and additional chemotherapy, that we see this level of disease, or this residual disease level, drop and drop and drop to the point where it's undetectable and there's no evidence left. What we know from monitoring patients is that sometimes we find that there's a low level left, and as we monitor this over time, that it can lead to a relapse maybe 1 to 2 years after treatment. And that is something we want to try and prevent if we can. And this is something we'll discuss a little bit more later on with treatment of residual disease, especially with special agents that are now licensed. However, other patients we know do not have a deep response, and what we see is they have a relatively high level of disease after treatment and essentially sometimes have an earlier relapse. And these are patients, we really want to understand these patients and identify them. And unfortunately for us, residual disease testing and MRD testing is not always available, and something that we're working very aggressively in Princess Margaret to develop to improve patient care both in AML and acute lymphoblastic leukemia. As regards next, the diagnostic process, pathway and assessment of response, I really often think, as you may have heard, I'm a pathologist as well as a clinician, even though I do relatively little pathology now. You know, as a hematologist, I think I have a toolbox, and my toolbox is helping me to diagnose your leukemia and to understand how aggressive it is and what treatment options are available. And so I wanted to explain this toolbox. So first of all, we do simple blood tests, the CBC, the biochemistry, and others, so we understand how well your kidneys work, how well your liver works, what's your white cell count, and how does that reflect. And often we can diagnose sometimes from the CBC leukemia, even though that's less and less rare because we often need to do other tests. And then we always want to do a history and examination to understand what your background is and how well you've been. From a bone marrow perspective, people could argue that maybe we don't need to do a bone marrow, but traditionally it's always been done in the diagnostics of acute leukemia. Definitely sometime in the future bone marrows will disappear, and it probably is one of our aims here in our group to work with other technologies. But currently in a bone marrow, we look at the morphology, we look at the cells under the microscope as the picture I show you, and we do these other specialist tests including flow cytometry, which looks at the surface markers on the cells and helps us classify the leukemia and help us understand if it's lymphoid or myeloid, or other. And then these molecular studies, cytogenetics and genomics, are critical to understand the prognosis of leukemia and treatment approach. And this has changed a lot from when the original FAB classification happened many years ago in the 60s and 70s, right up to this point in the 2017 classification we have at the moment. ALL is not one disease. It's several different types of disease, each with a distinct prognosis, maybe eventually each with a distinct treatment approach. At the moment, treatment is not necessarily differentiated for all of them, but certainly needs to be considered. And one of the things we want to talk about as we talk about the diagnosis of ALL is the challenges that we're facing in the diagnosis of ALL at the moment. And remembering, I always try to say to patients, you know, at the start when we're patiently awaiting to understand exactly what's going on with the leukemia, I say that that's the most important step, because with the diagnosis, we can always make a plan on the best treatment. In ALL, definitely in children and adults, there's different approaches, and I've realized in hindsight, I apologize that this is not the easiest to look at, but if you picked out a specific type of leukemia that you can see here called hyperdiploid leukemia, which traditionally has a good prognosis, you can see that it's much more common in children than in adults. Similarly, Philadelphia chromosome positive ALL, which many patients are aware of and have, you can see that this is more common in adults than children. And so we see that this difference across, and it's definitely different mechanisms, different biology at play. And each of these different types have distinct prognoses and distinct approaches. However, these are changing a lot. So you can see that traditionally Philadelphia positive ALL has had a poor prognosis, but this is definitely going to change with and I'm going to show you some of the recent studies and how this has changed. So this is a very dynamic process that we're always monitoring. From a practical perspective, different types of leukemia present unique challenges at diagnosis and in remission even. And I want to present work that's been kindly funded by the Leukemia Lymphoma Society that I'm doing with my collaborators, Dr. Mark Minden and Dr. Jared Simpson. And one of the challenges for us as hematologists is understanding this rare type of leukemia called mixed lineage leukemia, or LLL. You can see that it goes across a broad spectrum of disease, both ALL and AML, and classically it affects both adults and children in several different subtypes. And these different subtypes of over 135 different markers or different binding partners that are associated with MLL are often difficult to diagnose. We have been working with a new type of sequencing called nanopore sequencing, which uses long reads of DNA going into a pore. So instead of traditional sequencing, which uses small reads of 100 base pairs, we use long reads to identify complex MLL translocations, and we want aiming to create specific residual disease primers for use in ddPCR. And we're about a year into this funding cycle with this work. We're very excited about it, slowly but surely processing the spectrum. This type of sequencing is particularly good at looking at structural variations, and that means kind of swapping of material between chromosomes, so large changes. And one of the things that we find with this is often better at identifying structural variations than other types of other types of approaches such as cytogenetics. So much so that we often kind of think about a patient that we have a challenge with, and this is the sequencing, and this is a picture, believe it or not, of 3 different time points in a patient: her T cells, cells at diagnosis, leukemia cells at diagnosis, and leukemia cells at relapse. And essentially we've sequenced all 3 of them to understand if she had an MLL translocation. Using traditional techniques, we weren't able to confirm it, but essentially we sent over a sample on Friday afternoon because we thought we might have a clinical trial. And essentially when we came back on Monday, we were able to identify that she does have a translocation involving MLL, a complex one, but it was there. And definitely this approach is something I see us using more and more in the future, where we're using extra technology to the best of its ability to help us to clarify diagnoses further. And we often see not just kind of the diagnosis or the changes that there at diagnosis, but it hopefully will help us understand the changes that are happening at relapse and also in remission to understand residual disease. I didn't realize I put in so much slides about this. I apologize. These are my 2 collaborators help me with this, Phil Zizarti and Mike Malner, and I should definitely acknowledge the hard work they're doing on this project. And we're actually planning to sequence more and more patients to help us refine and understand the complex structural variations that are happening in MLL. The other type of leukemia or ALL, which is difficult to understand and difficult to diagnose, is Philadelphia-like ALL. If you think back to the classification that I showed you, this is a provisional entry in the recent classification for leukemias, and essentially something that has been understood over the last decade or so by different groups, both in St. Jude in the States and others. It is a specific type of ALL with distinct translocations. Those are swapping of material between chromosomes. It has a genetic gene expression profile similar to Philadelphia positive ALL, and we know that it has a poor prognosis in children. And because it looks like or appears similar to Philadelphia positive ALL, it's also known as Philadelphia-like or PH-like. Hematologists, being lazy, always shorten things down, you might notice. And essentially, the real challenge with this is diagnosis. It has a very complex diagnostic pathway relying on flow cytometry, which I mentioned before, microarrays, which are commonly not available in many diagnostic labs, FISH and others. And at the present time, we are doing immunophenotyping for CRLF2 expression, but we have not yet developed the microarray for Philadelphia-like, but hopefully this will happen in the near future. This pathway, as you can imagine, presents unique challenges for any laboratory. This form of leukemia is becoming increasingly important, and it's increasingly important because we understand it has a poor prognosis and we understand the complexity of diagnosis. And we can try and identify the CRLF2, but don't always have targeted approaches available to try and optimize the treatment. And our understanding of this disease is really in evolution. And what I mean by that is that we're still trying to understanding how it changes across the different age groups of patients. And this is a good example. We can see that in PH, like in children, it makes up only 10%, but as you get older in young adults, it makes up 28%. And to try and understand the impact of this is something that is becoming increasingly important in leukemia and ALL, and many groups are working on it and trying to improve approach. As regards from an adult perspective, I think the previous one I showed you was children. We know that it does exist in adults, and that this is a study of 318 patients published last year, done by Wendy Stock in the States, and it showed that people with a Philadelphia-like signature had a poor prognosis. And you can see this here. These are patients with the signature, and these are patients without the signature, and people without the signature are surviving much longer and have a much better outcome. So that's just diagnostics. Next, I want to talk about the impact of chemotherapy in ALL. And ALL is a unique disease and something that's been obviously around for a long time, but many people maybe don't always know that it was ALL the treatment started. And I don't know if any of you have read this book called The Emperor of All Maladies by Sid Mukherjee, who's based in Boston, but essentially this is the story of chemotherapy. That chemotherapy started with a gentleman called Sidney Farber in Boston, in Children's Hospital in Boston. A very interesting story about trying to be determined. He was a pathologist who thought that folic acid would help with leukemia treatment, and he gave it to some children at the time, and their leukemia got worse. So being the logical man that he was, he tried antifolate and found that that actually improved treatment and is the basis of methotrexate today, which is the backbone of a large proportion of treatment in ALL. And what we know is that this man, through his early work, has really revolutionized chemotherapy as we know it for all tumors, but in particular leukemia. For traditional chemotherapeutic approaches, we know that many groups will either use pediatric-based regimens or hyper-CVAD, and both of them have many drugs in common, including steroids, asparaginase, methotrexate, cytarabine, and others. And local protocols will vary around the country and around the world for that matter. What we know from our experience in Princess Margaret is that we gave a pediatric-based regimen, originally the Dana-Farber protocol, which is developed by Sidney Farber that I mentioned a few seconds ago. And for our patients between the age of 18 and 60, we know that we have a complete remission rate of 90% and survival overall of 71%, even though that can be reduced. And so it's this traditional chemotherapy that's the backbone of a lot of research that's done in leukemia and a lot of the chemotherapy approaches. And I'm now going to discuss specific types and how that might have or at relapse and understand the eventual diseases. I must say I was cheating a bit and I did TALL first because overall it is a rarer entity compared to BALL, which is much more common. It makes up about 15% of all cases of ALL. It's most common in adults and typically presents with either a high white cell count or extramedullary involvement. So what does that mean? It means involvement of the lymph nodes, or sometimes many times presents with a mass in the chest. It's important that you people differentiate between acute lymphoblastic leukemia, which is involved in the bone marrow, or lymphoblastic lymphoma, which is typically in a mediastinum, in more like in the lymph nodes or the lymph glands, as people often call it. Even though there can be crossover, typically they're two distinct entities. TALL is often thought to have a poorer outcome than BALL when you think about different entities, and this is from a study presented back showing that there was a 5-year relapse risk of 42%, and that was most common at 12 months. And this is something people are trying to improve all the time. We know that risk factors for relapse are typically CNS involvement, which is involvement of either the lymph nodes or a lump in the brain, a high white cell count, a presentation over 100, a specific subtype called early T-cell precursor ALL, or ETP ALL, which is also, excuse me, a new precursor entity in the classification I mentioned at the start. Complex karyotype, which is developed by cytogenetics. Failure to achieve remission after you have your first cycle of induction, or first or second cycle of induction. This marker in flow cytometry called CD1A negativity, and the presence of minimal residual disease. Back to our iceberg before, so we remember that this residual disease is the disease below the surface, not necessarily something that we can measure with a microscope, but we need special techniques like flow cytometry and molecular testing. When it's looked at, when it looked at a group of patients who, this is a study that was 100 patients, over 100 patients who had residual disease testing 1 month before transplant, it was found that those patients who were residual disease positive, which was a test done by flow cytometry, had a much higher risk of relapse than those who were residual disease negative. And interestingly, they found no difference according to kind of TALL subtypes, but that this residual disease is important. And I think something all of us need to understand better. In TLL, if we want to talk about novel treatment options and where the treatment's going as regards at both a diagnosis and relapse, I think it's very similar. So I want to look at the different treatment options that are available. First of all, many patients will get chemotherapy if they've had a pediatric-based protocol, and they can sometimes then get hyper-CVAD. And other centres will use FLAG-IDA depending on the type of TALL and the different approaches. Nelarabine has shown good responses. This is a kind of slightly more novel type of leukemia that's been developed. It has shown 30% responses in treatment. When it's used in combination with other drugs, that can increase up to 60%. Certainly the issue with nelarabine can be increased toxicity, in particular in relation to neurological toxicity such as seizures and several others. There has been more toxicity seen when used in relapse, but actually, there's still studies ongoing and newly diagnosed patients to explore the options in patients. The other drug that's being explored is liposomal vincristine. Vincristine is the backbone of many treatments in ALL. However, a liposomal version has shown 20% responses in relapsed refractory TALL, and certainly is one of the options that can be considered. Venetoclax is a very unusual agent that's now very common in treatment in AML, and that certainly has been used in combination with chemotherapy, and in rare reports has shown 60% responses. However, this needs to be explored further. And finally, daratumumab. This is a monoclonal antibody that has been developed and is often used in myeloma treatment, but now is being used in rare cases in TALL, and we've used it here in a couple of patients in Princess Margaret. And this is something that also is being explored further in different TALL populations, both in remission or in relapse, and upfront. Okay, I don't know where we're going for time. Let me just check before I, oh yes, halfway. Okay, good. So finally, BALL to talk about this. So please bear with me. This is a mammoth task. I found, I think I did the TALL first because I thought it was easier to manage. In BALL, there's been a huge amount of changes, a lot of different treatment options available. And I really wanted to break it down into Philadelphia positive and Philadelphia negative. When we talk about BALL, we know that the younger the patient, the higher the impact of chemotherapy, with over 90% survival in children, that there has been a lot of toxicity in the past, but there's a move away from that to more targeted approaches, and that there's obviously the major development in immunotherapy. In BALL, we know that again, I think I've given you like about 5 or 7 different types of this picture showing how diverse this disease is and how it changes over time, and taking out both Philadelphia-like and this Philadelphia positive ALL, there's several other subtypes each to be considered, each having a distinct prognosis, and definitely something that's going to change treatment more and more in the future. And a pathologist first, maybe, I think the diagnosis of these entities and understanding each distinct type and how it responds to treatment will improve more and more with time as we move on and do more research, and probably with the development of artificial intelligence. Philadelphia positive ALL is probably most common in adults, and essentially it occurs in 50% of patients over the age of 50. Historically, it had a very poor prognosis until the development of tyrosine kinase inhibitors such as imatinib, dasatinib, nilotinib, and others. And this is a classical description of the Philadelphia chromosome, showing the swapping of material between chromosome 9 and 22. We know that one of the first studies that was done in the UK, and we can show that in this group, essentially in 2014, there was a trial of 400 patients, some of them having imatinib at the very start of the treatment and others having imatinib introduced at various different time points during their treatment. When they first of all compared imatinib, the outcomes with imatinib compared to the pre-imatinib era, you can see there was a significant improvement in survival. And then further, oh, sorry, I think I previously had a slide in there about when adding in the timing, and they show that basically the earlier you started imatinib, the better the outcome. I apologize. I think I was cleaning up when I took that one out. The next thing I want to talk about is then that dasatinib was also being combined with low intensity chemotherapy in elderly patients. And there's several reasons to do this. I think it was understood that the toxicity of ALL treatment was very high, especially when combined with these tyrosine kinase inhibitors. And so this study was developed and essentially showed improved responses when dasatinib was combined with low intensity chemotherapy, with over 36% 5-year survival in older patients over the age of 55. And that interesting study also allowed for prospective monitoring of residual disease, so that more and more patients could be monitored to understand how the disease was changing over time. Interestingly, in this study, when they looked, there was the discovery of this famous mutation some of you may have heard of, called a T315I mutation. And this T315I mutation historically has been resistant to most TKIs, and essentially presented a unique challenge to many groups because there were such poor outcomes compared to other patients, as is demonstrated here. And essentially, what happened at that point is that ponatinib was developed, which is, I always get it mixed up between third and fourth generation, I apologize. It's a new generation TKI and was combined with hypercivide in those patients with T315I mutations, and it showed absolutely superb results compared to historical, and certainly is now the standard for this group of patients and commonly screened for when we know people are relapsing with Philadelphia positive ALL. It's rare at presentation but common at relapse. Excuse me. Finally, this is the most exciting study that's been published in a long time in leukemia. This is published just this year on October 12th, and essentially is a study of over 100 patients who received either dasatinib in combination with blinatumomab in an early phase study for Philadelphia positive ALL. And what we know is that patients who had this combination, step ahead, I apologize, showed excellent overall survival of 95% and disease-free survival, with no evidence of relapse of 88% with 18 months of follow-up. It was thought that many factors contributed to the excellent outcomes with this study, in particular the low incidence of toxicity with induction chemotherapy, the excellent response to treatment, which was monitored using minimal residual disease testing, and also the low mortality after bone marrow transplant, which some patients had done. And we know that this is the future in Philadelphia positive ALL, that's chemotherapy-free approach. And I think this is one of the many studies that's going to be done going forward, using both dasatinib and other agents such as blinatumomab and inotuzumab in combination to reduce the overall morbidity of treatment, so there's less and less side effects, which I know many patients struggle with. Okay, Philadelphia positive ALL done. Philadelphia negative ALL. So multiple subtypes with a distinct prognosis. MRD plays a key role in risk stratification, and treatment options are rapidly expanding. So back to this picture that I showed you before, which I didn't, and essentially the first thing I want to highlight is that we know in both adults and children that minimal residual disease testing is critically important. And this is a historical study that was done in Germany when they essentially divided children into kind of low, median and high risk of, according to their MRD status at the end of induction and consolidation treatment. And those patients essentially who are negative both time points had excellent responses. And so this is not about this is about the treatment that we give, and we know that people are more responsive to the chemotherapy we give, but being able to identify and these good risk patients or likewise these poor risk patients has allowed many risk stratification studies in ALL so that you can refine how much chemotherapy you need to give. And this is an important study and something that's commonly done in childhood ALL, though less likely in adult ALL. However, certainly minimal residual disease is equally important, and what we know is that in this very strict MRD study that was done now in 2006, was done in nearly 200 patients, they showed across all time points that if you were MRD negative, that your outcome was significantly better than those who were MRD positive. And this was testing was done in multiple time points across treatment, something like the dynamic process I showed you at the start, and certainly will probably change treatment as we move on in the future. In our group here in Princess Margaret, one of my colleagues, Dr. Anne Tirenz, is working on developing a very sensitive flow cytometry method, and essentially has, while we have this in place already, she's essentially improved the sensitivity further, and now we can find leukemia cells in 1 in a million cells, which will really help us to improve, to understand how well our patients are responding to treatment, and we're very excited about this development, and kudos to Anne for all the hard work she does in this area. As regards treatment and what treatment seems to be helping, we know that there's several new treatments, and I don't know if I'm going to fly through them, but I'm conscious of time and questions, so I'm certainly not going to go into too much detail. What I would say is that inotuzumab ozogamicin is certainly a new treatment. This is a monoclonal antibody that's targeted against CD22. And we know that when it's been used in relapsed refractory patients, that there's been a significant improvement in clinical outcomes and certainly a reduced risk of relapse and improved overall survival. We're understanding this drug more and more, and we use it more often in clinical practice. And I think in the future, it's certainly going to change our approach, and certainly at the moment is being used in relapse, but hopefully in the future will be used at diagnosis to help us reduce toxicity in patients. If we go back to Philadelphia-like TLL, which I focused on a lot at the start as regards the importance of it at diagnosis, what I would say to you is that it seems there's many agents that might be available to target this type of leukemia, which, as we know, has a poor prognosis. So given the different subtypes, there's different treatments, all of which are typically oral treatments, or some of them maybe some rare IV treatments or even CAR T cells. And certainly more and more treatments are in development in this group that have a poor outcome. There's several studies ongoing in the Children's Oncology Group in the US and others across the world, where there's been a real clear approach into how to diagnose and how to treat these subgroups, and how these are all in development and probably not ready for clinical practice as yet, but certainly being considered more and more, and probably will evolve in the next few years. As regards immunotherapy in ALL, I think that there's kind of two types, both kind of blinatumomab, which is a monoclonal antibody, a BiTE antibody as it's known, and also CAR T cells, which many people around the world are aware of. And certainly we get asked a lot of questions about. So we're going to talk about these two entities in hand and see where how we're going to approach or where they could change patient care. So blinatumomab has several successful outcomes in relapsed refractory chemotherapy, and so much so now it's being kind of changed to use in all patients at diagnosis, even though it's not yet available in Canada. And certainly this is being done in clinical trials, and many are being developed. It's a monoclonal antibody essentially that binds to both the CD3 T cells and to CD19, and essentially leads to a cytotoxic reaction, which often has a side effect called cytokine release syndrome. However, it's been extremely effective at treating patients, and it's a very important step in ALL treatment. We know that there's superior survival outcomes when it's used in relapse, and essentially in 405 patients, there was a doubling in the overall survival and essentially a reduction in the relapse rate when it was used. And this is one of the first premium papers that was done in 2017. One of the things I wanted to mention about blinatumomab also is the effect that it's extremely effective in clearing residual disease. So after talking so much about how important minimal residual disease is in ALL, we know that if we can get rid of this residual disease, that people have improved outcomes, whether they go to transplant or just continue on chemotherapy alone. And this is something that's in the process of being licensed, I think, in Ontario and in Canada, and certainly is considered for many of our patients, even though it's difficult to get the drug otherwise. Finally, talking about CAR T cells. So such a good story about the impact of science in clinical practice, from when these cells were first developed in Israel to how they've gone step by step through the clinical practice and now are common practice in pediatric and adult ALL. It's a simple process, or sorry, excuse me, I take that back. It's a complicated process to actually create the CAR T cells. T cells are removed from the patient's blood, and essentially there's a process to make the T cells in the laboratory. And the interesting thing about this is that every company has a different approach. There's often many of this kind of developments in CAR T cells are going to be involved in how they're made, how to successfully make sure that it works. And essentially that typically takes anywhere up to a month to typically for most companies to do. And essentially what happens is that they come back and they're infused into the patient, and it activates the T cells to kill the cancer that currently patients have, whether it's a leukemia or other types. They've become extremely famous, as you know, and there's been many different types licensed. And I apologize to you in advance. I really struggle with the pronunciation of these drugs, so I just kind of generically call them CAR T cells, CD19 CAR T cells. I don't know why they've been called as such complicated names, but certainly they're having an impact, particularly in pediatrics. The first study that published was done in 30 patients and showed that there was significant reduction in relapse and excellent overall survival in patients who received this treatment. There's known adverse events of this treatment, and they're relatively common. And I think one of the refinements that's happened in clinical practice is our understanding of the impact of these and how to reduce them. And there's many different techniques available in clinical practice to reduce the effects. The most common side effect that's known is cytokine release syndrome, and many of those have neurological involvement. And then there can be, of course, infection, which is common. Rarely there's tumor lysis syndrome. And I think, you know, from our experience, cytokine release is the most common. As regards the long-term effects and the long-term response, this is a beautiful paper published by Jay Park in 2018 in the New England Journal of Medicine, showing that essentially for those patients, there has been excellent remission rates that have been ongoing. This is interesting because it had a 5-year follow-up, and so has had a significant impact in practice and showed that there can be durability of response, which is important. And essentially these responses can be really excellent with only a no response in a small portion of patients, but MRD negative response. And we know that patients who are MRD negative remission overall have increased expression of CAR T in the blood and better overall remission, or complete remission overall, excuse me. And that we know that there can be long-term sustained effects, and you can see that after kind of 1.5 to 2 years that there's been a sustained response in all patients in both overall survival and event-free survival, which is important considering the toxicity of these drugs. Again, MRD status does impact survival, and we know that patients who are MRD negative have better overall responses compared to those who are MRD positive, and this is both event-free survival and overall survival. And actually, when it was looked at the transplant impact on these patients, it seems that that basically patients who are MRD negative, that essentially there was similar outcomes whether they had transplant or did not, and again, overall survival or relapse-free survival. As regards the reported toxic effects of CAR T cells, cytokine release syndrome, as I mentioned before, there's, however, some other common things. We can see B-cell aplasia and hypogammaglobulinemia. That essentially is your reduced, that leads to an increased risk of infection, particularly chest infections, and is commonly screened for now in patients. There can be rashes, there can be hemophagocytic syndrome, which is a much rarer complication, and neurological effects. Many of these effects are acute and happen around the time of the infusion and are not typically lasting, and we're still trying to understand how these last on an ongoing basis. So I'm nearly there. I want to talk about things I didn't discuss because it feels like there was a lot I didn't. In particular, we did not talk anymore or in any great detail about molecular diagnostics, not a lot of discussion about late effects. I purposely didn't talk about COVID-19, and I understand it's prevalent in all of our lives and how we live and work on a day-to-day basis, but I'm happy to take any further questions on that matter. In summary, I want to tell you that I've talked about the diagnostics, about the importance of Philadelphia-like ALL, and MRD assessment, and how critical it will be in clinical practice in all forms of leukemia. In TLL, there are treatment options, but more treatment options are needed. In BALL, that MRD is an excellent risk stratifier and may help us to guide treatment to where it's needed for all of our patients. And it seems that the future directions in ALL are going to be the combination of immunotherapy with an optimal chemotherapeutic backbone, essentially trying to reduce the toxicity of treatment. That I hope that more genomic analysis and more testing for MRD and others will essentially identify high-risk groups that need more chemotherapy, and equally low-risk groups who need less chemotherapy and so will have less toxicity with treatment. That you know that there's a wide application of kind of tyrosine kinase inhibitors in clinical practice, and that maybe there may be a decreasing role for bone marrow transplant. However, that needs to be defined further. And now I'm happy to take any questions.
Perfect. Thank you, Dr. Murphy, for sharing your time and your expertise today. You know, we often talk and hear about the incredible momentum that we're seeing in blood cancer research, and how rapidly care is changing and how much of a shift we're seeing between, you know, traditional therapies to targeted. So it was so fascinating to hear you talk today, especially about ALL, which is one of the blood cancers that's seen tremendous amount of growth in survival rates. Mm-hmm. So yeah, thank you so much. It is now time for some questions and answers. And I'll start with a few questions that were submitted in advance of today's session, and I see there are a few new ones popping up. So we'll try to get to as many as possible. I just want to say to anybody who might be asking very specific questions about your personal diagnosis or experience, that we will try to get to it. And if not, and if we feel now is not the right place for it, we will try to follow up with you outside of this session. One of the questions is, how often do people with ALL develop other cancers and or other serious conditions?
So it's relatively rare. When you think about the late effects, it's known as regards, and I didn't discuss this, so I didn't think I'd have enough time. The late effects of treatment essentially are kind of there's a large number, and it's well known in ALL, in particular, the risk of any heart problems, the risk of kind of thyroid and other endocrine problems. But the risk of secondary cancers is relatively rare, and when I looked at it and quoted numbers was less than 1%, and probably maybe in parallel with with kind of control groups in the region. The main impact of late effects is definitely on the heart and on physique in general. And certainly one of the things we want to encourage patients to do is be as active as possible after their treatment to try and maintain all of the risk factors that we know exist in the population, monitor their cholesterol, stay active, try and keep their weight down, etc. All of things really help in reducing the impact of late effects and help to overall improve survival in this population.
Fantastic, thank you. One of the questions we received live during the event is, what's the main difference between ALL and CLL? Are the treatments the same?
ALL and CLL are very different beasts altogether. So the clue is probably in the name. ALL is acute lymphoblastic leukemia and CLL is chronic lymphocytic leukemia. So essentially ALL is an acute disease that typically happens over 1 to 2 months as a maximum and develops very acutely. It's universally fatal if not treated very quickly. And you will notice that in practice that many patients are brought into hospital very quickly and diagnosed. And we know that it's something that needs to be treated urgently. CLL, on the other hand, is something that many patients in the world will live with on a regular basis. These cells live in their blood and they very rarely need treatment or not very often. And certainly it's a very more slow growing and chronic disease and you do not always need treatment for it. And in fact, many people live and die with CLL and it's a common thing that we used to say a lot in clinical practice. However, that varies obviously from patient to patient.
Okay, fantastic, thank you. One of our participants asked or commented that coincidentally, they are currently attached to blinatumomab as we speak and are also in Canada. So it definitely is accessible in Canada. They're wondering what the comments are about only doing I'm so sorry, I'm not saying it well, blinatumomab when you get into MRD negative and stopping there, or continuing with a bone marrow transplant is either a common approach. Yeah. And I'm sorry if I said the word wrong.
You can do what maybe I should have done what we do. We all call it Blin because it's much easier to pronounce it that way, I think. The first thing I would say is, we routinely use it in our relapsed refractory patients and we often have patients at home hooked up to it. I think there's so many factors. I agree. If you become MRD negative, the decision whether to go to transplant or not is important. I think there's loads of reasons and options to discuss with your own hematologist about that. Being important are how fit you are for transplant, what kind of donor you have available, and essentially how good and how durable is your response to your treatment. And all of these things, it's not something that you say for one patient you're going to do it, another patient you don't. And I can tell you personally, I've had patients where I've done both. And so I think it's a very specific issue and you just talk to your hematologist and try and feel what you are, the risks and benefits of treatment. And even many patients in this scenario might benefit from seeing the transplant team to discuss it with them and might feel that the toxicity of transplant is not something they want to go ahead with. And it's a very really personalized approach that patients need. Oh, sorry, I can't hear you, Netta, for some reason.
Oh, sorry, I had muted myself. Thank you so much. The next question is, I've been told that kidney stones are common with ALL diagnosis and chemotherapy. Is this true, and what can be done to reduce or eliminate this from occurring?
It's not something I'm aware of. I wouldn't consider it particularly common in our ALL population, and I apologize. I don't want to contradict anyone. I confidently can say to you, I am not a kidney stone expert. I'm a hematologist. And so if you have questions about kidney stones, get referred to urologists and they can help you with management and approach, but not something we see extremely commonly in our patients.
Okay, thank you for that. One of our participants is asking, is CAR T cell possible in treating TALL?
The most common uses for it at the moment are in BLL. TLLs are being developed, but very slowly developed. And there's reasons for this as regards the unique approach. So CD19 is a very good target to have because essentially if you kind of target that response, you don't impact on many other cells in the body. Targets for T cells such as CD3, CD1, and CD5 and 7 are common things that are being developed, but there's a lot of side effects being understood about this approach. And so the target that needs to be identified and how to actually target it as regards what type of CAR T to use are currently being studied and being considered. Very likely it will come, but certainly not licensed yet, and clinical trials are certainly early to come as well, soon.
Perfect. Thank you very much. One participant is asking, can you talk about the Dana-Farber protocol for adults with ALL?
Yeah, sure, I can. It's our most common protocol that we use here in Princess Margaret. It's a multi-step protocol that's used with kind of 4 main steps, being induction, CNS phase, intensification, and maintenance. It can be a 3-year-long protocol. Sometimes I don't tell my patients at the start how long it is. I understand it's a long commitment to chemotherapy. I've shown you our Princess Margaret results. We've had excellent outcomes. We tailor our protocol according to whether you have Philadelphia positive or negative, and consider the most important kind of aspects of treatment in Philadelphia negative are steroids and the use of asparaginase, which are both extremely important for treatment outcomes. For Philadelphia positive, we certainly use slightly less chemo in combination with the tyrosine kinase inhibitor, and typically here in Princess Margaret we use imatinib. We have seen excellent outcomes, and certainly something that we continue to use. However, I know that many of my colleagues would love to step away from chemotherapy to be able to use blinatumomab up front, and certainly that's something that's being worked on. We have a new leukemia group, the Canadian Society of Leukemia, and certainly something that we're working on from that perspective.
Fantastic, thank you. The next question is, has there been any research regarding hereditary aspects of ALL? In this participant's scenario, they have ALL and their mother has CLL.
Hereditary ALL, hereditary syndromes in leukemia are slowly being described. In acute myeloid leukemia, they certainly at the moment make up 10% and may make up more in the future. In ALL, I think, I'm trying to think back to my brain, there's been one described, but obviously it's typically, it's very relatively rare and much less common. I would not, CLL is a disease of old age, and as you get older, your risk of CLL increases. So you will notice from the age of 60 to the age of 90 that their incidence of CLL increases steadily, and it's really considered a disease of old age. ALL, on the other hand, is not that. We see it most commonly in children. There's several theories on what that might be the case, so yet not to be confirmed for the exact cause. And so on that basis, they're not very similar, so may not necessarily be hereditary in that case. From our perspective, when we screen patients for hereditary cancers, we often look for 2 first-degree relatives. So if there was another brother or sister who had another type of leukemia, then we might often consider testing. And we have we're setting up a testing pathway here in Toronto at the moment. One of my colleagues, Dr. Andre Shu and Dr. Jose Mario Cappucci, are setting up that for acute leukemias, though predominantly myeloid at the moment. And we have a strong relationship with an international expert in Chicago called Dr. Lucy Godley.
Fantastic, great, thank you. This is a slightly longer question, so just bear with me as I read it. How do you currently manage CV risk factors associated with some treatments like TKIs? Specifically, do you manage these comorbidities yourself, or do you refer patients to cardiologists or their family physicians? This participant asked because it seems that some cardiologists hesitate to follow patients with leukemia other than initial consult. And they also said, thank you for the wonderful talk.
Okay, thank you very much for the feedback. It's really complicated with TKIs, and essentially all of our understanding of TKIs, so there's a multi-generations now. So imatinib we use the most commonly and associated with less cardiovascular side effects, and then ponatinib and nilotinib are associated with more dramatic vascular side effects. And between, for many patients might know that chronic myeloid leukemia, TKIs are used far more commonly in that group. They're used in all the patients. And so in CML, there is a strong tendency to check for cholesterol, to get a cardiologist involved, to understand the cardiovascular risk factors and work to reduce them. And every physician has a different approach. I must say, even here in Princess Margaret, some physicians will respond to a cardiologist and have a working relationship, and others don't always do that and ask the patient to be vigilant themselves, or will routinely check cholesterol and other things. And I don't routinely treat CML, so I'm not trying to lie, but I may get this, everyone has a slightly different approach. In ALL at the moment, we certainly can look for cardiovascular risk factors and screen for cholesterol, especially with ponatinib, which is associated with many severe side effects. I won't lie, I may have forgotten it to do. I actually don't have any ponatinib patients at the moment, so I can't say I've lied. I just, when I do it, I have to stop and think about it. And interestingly, with ponatinib, there's a strong education component for the physicians to consider doing it because of the known vascular side effects. In real life, of course, we should all be monitoring our cholesterol. We should all be active. We should all be trying to keep our weight down and to be as healthy as possible. But in that group, it's particularly important. So I think a roundabout way of saying I'm not sure was the answer to that one. I apologize.
It's complicated. There's many layers to consider. I'm going to ask two more questions, one more from our live chat and one more related to our current time of living through COVID. Mm-hmm. The first question is, I've been a TALL patient at PMH for the past 2.5 years. How routinely is MRD measured throughout treatment?
So we are certainly working on developing that pathway. What we do at the moment is we traditionally measure it post-induction, and at that point we kind of often make decisions about patients. Other than that, we don't routinely measure it unless we can with specific subtypes, including Philadelphia positive. It's measured quite routinely. It's something that we're really working to develop. Dr. Shu, who's one of my senior colleagues here, has been working on this for many years. Something we want patients to advocate for. We want you to go to LLS and to your government or anyone you can think about and try and fund this, because we think it's really important for treatment, and why you notice it's been the thrust of my talk. Yeah.
Wonderful. And then the last question is, what extra precautions are being taken for those having a donor stem cell transplant and COVID risk, especially those who are staying in hospital rooms at the request of their transplant team?
Well, again, something that happens differently across the country and the world, for that matter, I can tell you. At the moment here, if we think a patient is at risk of, might have COVID, we're isolating them with airborne precautions. And something, actually, this has been a very dynamic process. Only yesterday, a new set of guidelines came out, and something we're revising on an ongoing basis. I think people need to be really vigilant. It's a very difficult disease to understand. We've been very fortunate that not many of our hematology patients have had it, and it's probably because naturally hematology patients are isolating anyhow, they're neutropenic, they're immunosuppressed, and all of the world, I kind of said it a while ago, the whole world understands now what it is to have leukemia and to isolate, and it certainly has totally changed, but I think every hospital has a slightly different protocol, and I'm not doing transplant here, and I know our transplant team here have been particularly vigilant, but essentially we want to be as safe as possible for all of our patients. And really, I think it's about doing the good things well, making sure you socially isolate, regular hand washing, making sure you're limiting your number of contacts, and trying to reduce the risk as much as possible.
Thank you. Thank you so much. To anybody whose questions remain unanswered, we do apologize. In the interest of time, we're going to move on. But as I mentioned earlier, an LLSC staff member will follow up with you to answer any remaining questions. Dr. Murphy, thank you again for joining us today. Your topic is so relevant and so important, and we're so happy to have a platform to welcome you to share your expertise. And also thank you to everybody who participated on our webcast today. Your questions were fantastic. I also want to thank our marquee sponsor, Astellas, and I also want to thank our sponsors, AbbVie, AstraZeneca, Bristol Myers Squibb, Celgene, Janssen, Jazz Pharmaceutical, Novartis, Paladin, and Pfizer. Before signing off, I do want to remind everybody, again, that we are here for you. If you're looking for resources and or support, do not hesitate to contact us. You can dial 1-833-222-4884 or by email at canadainfo@lls.org. Also, please note a short survey will be sent to you after this webcast. Take the moment, respond, and help give us feedback on how we can improve events like this in the future. You know, at the end of the day, we want to make sure that you get everything you could possibly get out of these conversations. So thank you for joining us. We hope that you participate in the AML conversation that's happening at 3 o'clock today. And tomorrow we will be hosting conversations on CLL and CML. Thank you, everybody. Have a great day.
Thank you.